Hello everyone. So we are here with the troubleshoot video for the topic preeclampsia. Preeclampsia is a very important topic. In this short video, you will get one marks question surely. Okay. दो तीन मार्क्स तो आ ही सकते हैं बट वन मार्क यू विल श्योरली गेट. Okay, please focus. All your mistakes are here. Do subscribe, like, and share my channel so that I too can get the encouragement and I too can make a nice teaching career. Okay, so we start here with etiology of the preeclampsia. What is the etiology? You all know around 20 weeks spiral arteries, the tunica media of the spiral artery is removed by the invasion of extravillous trophoblast. If this invasion does not occur, then preeclampsia occur or this invasion is poor. Okay, so once again, every artery has three layers: tunica interna, media, and externa. Media is the most muscular layer. In the placenta, the branch of the uterine artery, the spiral artery is spiral artery tunica media is replaced by the extravillous trophoblast. How you will remember that it is extravillous trophoblast? Because villous trophoblast makes villi. Extravillous trophoblast do extra work. So the invasion of the spiral arteries is done by extravillous trophoblast, and this circulation, uh, this invasion is around at 20 weeks. If this invasion does not occur, then the whole spiral arteries goes into vasospasm, and this vasospasm occurs slowly into the whole mother's body and also in the fetus. Okay, if it will occur in the fetus, it will cause IUGR. Now you only tell me when vasospasm occurs, then thromboxane A2 will increase or decrease? Thromboxane A2 will increase. Thromboxane A2 is a vasoconstrictor. Okay, prostaglandin E1 is a it's not E1 here, it is I. Okay, it is prostaglandin I. So prostaglandin I is basically a vasodilator. So vasodilator will decrease when vasospasm will occur. Then the vasodilators will decrease, and the vasoconstrictor thromboxane A2 will increase, and all this occurs at 20 weeks. So, if there is vasospasm at 20 weeks, then the patient will manifest as preeclampsia. Okay, then in the mother, when the slowly whole the body goes, whole the vessels goes into vasospasm, then what will happen in the mother? Help will occur, right? What is help? Mainly hemolysis and platelets decrease. This is what happens to the hematology. Then at the other side there occurs liver enzymes increase. Okay, liver and kidney failure occurs because in them also there is vasospasm, and in the brain cerebral vessels also there is vasospasm. So brain, in due to the vasospasm, goes into hypoxia and then eclampsia. Okay, you all know what is eclampsia. Then what are the risk factors? So how you are going to remember the risk factors? As you all know, without I tell you, that the risk factor is always the previous history of the same diseases. Because what is happening here? Here the spiral arteries tunica media is being removed by the extravillous trophoblast. So if it is a primi gravida patient, also first time this action has to be done. Okay, so if it will not happen, then it will not happen in successive pregnancies also. right? So if it happens in the one, then it will happen in the other pregnancies also. So you have to write the risk factor as primi gravida. Then at the both extremes of the age it is risky. Even if the mother is teenage, then it's again risky, because the spiral arteries, the uterine artery sub branch is not matured. Okay, it is not matured. Spiral artery sub branch is not matured, so it is the very difficult to remove that spiral artery tunica media, so it results into vasospasm. Similarly, in the elderly gravida blood vessels, there is lot of atherosclerosis as compared to the young. So again, the removal of the tunica media becomes difficult. In multiple pregnancy, there is preeclampsia, because very large placenta is there. To remove each spiral artery tunica media becomes difficult. Okay, so a very large placenta means large removal of the tunica media of the spiral arteries leads to preeclampsia. Thrombophilia. In all the thrombosis diseases, there will be formation of thrombi, and thrombi leads to more and more, or you can say thrombi formation leads to more and more preeclampsia. But because what happened after the spasm in the placenta, thrombosis occurs right after the spasm. So if there is thrombophilia, then more and more preeclampsia will occur. So that was all about the risk factors. Only this much risk factors are important. There are other risk factors too, but mainly you learn this. Now let us study the management. Okay, so you all know that mild preeclampsia is if the BP is less than 160 by 110. Here I would like to tell you students, if even 1 BP is written, for example, they have given a patient came with antenatal patient came at 37 weeks with BP 150 by 110. So only 1 BP is high, but still you will label it as severe preeclampsia. Okay, in the mild preeclampsia, antihypertensive role is controversial. We don't give MEG sulfate because the tendency of eclampsia is very very less in mild, so we don't give magnesium sulfate. Role of antihypertensive is controversial, so we have to terminate at 37 weeks. Okay, so what is the gestation where we have to terminate? We have to terminate at 37 weeks. In the severe preeclampsia, we have to give antihypertension, magnesium sulfate, and we have to terminate at 34 weeks. In the eclampsia, please listen carefully. In the eclampsia, because patient is having fits. In the fits, the patient aspiration occurs, वो अपनी गैस्ट्रिक सिक्रीशन एस्पिरेट कर जाएगा, तो उसकी डेथ हो जाएगी. Patient will soon meet the death. So first step in the eclampsia is, as the fits occur, let us first remove the danger of aspiration by maintaining the airway. Whenever they ask you eclampsia, please see what they are asking you. First step, important step, both are maintain the airway, because if that patient will aspirate, the patient will die. Okay, then now we come the treatment. Now the prophylaxis and the therapeutic both for eclampsia is magnesium sulfate. No doubt we give antihypertensive, but now because the toxemia is occurring too much, the brain has gone into the fits phase, now we have to terminate the pregnancy. Okay, now HELP. What is the treatment of HELP? HELP is not that dangerous like eclampsia, because in eclampsia brain is suffering from From in eclampsia, the brain is suffering from hypoxia. It can lead to permanent damage. If the conversions prolong, then it will lead to permanent damage of the brain. Okay, so again I tell you that in the case of the eclampsia, in the case of the help, the conditions are not that serious. So termination is not the first step. If the pregnancy is less than 34 weeks, we have some time. We can give the patient betamethasone. So help is not that dangerous. We can have 2 days for the betamethasone action, and for the lung maturity. So if it is less than 34 weeks, so we should give a betamethasone to the patient for the lungs maturity. Okay, or dexamethasone, whatever. And if it is more than 34 weeks, then we have to terminate. Now on the mode of delivery, there is lot of confusions. Please listen carefully. In preeclampsia, there is hemolysis. Platelet counts decrease. Platelet counts decrease. There is hemolysis. Chances of this patient to go into DIC is very high. That is why we terminate. Similarly in the abruption, there behind the clot which is behind the placenta, it goes into the circulation and it releases thromboplastin and the patient goes into DIC. If IUD is left there in the mother's uterus, then again after 2 months there is chances that the patient will go into DIC. Chances are late, but there are chances that the IUD can go into DIC. So beta, here I would like to tell you, keep please in all these three cases, as the patient has tendency to go into DIC, you are not going to do cesarean as first step unless and until there is any obstetric indication. Because if we will do the DIC in the patient in which there is DIC tendencies, if we will do the cesarean, then what will happen? Then the patient will more or easily go into DIC. Okay, because in cesarean we give lot of incisions, so patient has to patient body has to clot the blood there, stop the bleeding. They will consume the clotting factors, and the tendency to go into the patient's tendency to go into the DIC increases. So that is why I always say, in preeclampsia, in abruption, in IUD, in all these three cases, please prefer normal delivery, because patient is having the tendency to go into DIC. We don't want to increase that tendency by doing cesarean. If there is any obs indication, please go for cesarean, otherwise not. That is why in the question of for previous cesarean also, their answer was to induce labor, because one LSCS, one lower segment cesarean section, can undergo VBAC. Okay, so please always prefer normal delivery in the case of preeclampsia, eclampsia, abruption and IUD. Let us see what are the complications. Some of the complication you all know: HELP, liver failure, renal failure, eclampsia. These are the complication you all know. Cerebral stroke, right? Some complication which you have to understand. Now see what is happening in preeclampsia is that the spiral arteries are under vasospasm, and soon there is spiral arteries thrombosis. Okay, spiral artery thrombosis. Spiral artery thrombosis is lead to abruption. The blood vessels in which thrombosis is there, they will more easily separate. They will more easily break. Right? So the patient of preeclampsia very easily goes into abruption. Now in abruption, you know that bleeding occurs and the bleeding goes into the uterine muscle. Now, when the bleeding is going into the uterus or the myometrium, then you tell me, will the uterus affects contractively or not? Uterus contract after the delivery, whether PPH will occur or not. Uterus will not contract because in this abruption uterus, uh, in the abruption uterus there is blood in the myometrium, so this myometrium cannot contract effectively, so this abruption uterus will be a cause of PPH. Then the patient also goes into DIC. Okay, and what are the fetal complications which occur? The fetal complications which occur are prematurity, because we are terminating. Why prematurity occurs? Because we are terminating the labor at 37 weeks in the case of mild preeclampsia, and in the case of severe preeclampsia we are terminating it at 34 weeks. So prematurity will happen. And why there is IUGR or IUD? Because the spasm which occurred in the spiral arteries, it also occurs in the fetus vessels, leading to IUGR and IUD. Okay, let's go to the next slide. Magnesium sulfate, lot of question. So what is Pritchard regime, which is most commonly given? It is loading dose 14. Yes, I know, you all know Pritchard regime is a regime of choice, but you should know this loading dose is 14 mg, 4 gram IV, 10 gram IM. Maintenance dose is 4 gram IM every 4 hourly. It's good you know it, but now you tell me when, up till how much the maintenance dose has to be given. It should be 24 hours after last fit or delivery, whichever is later. Okay, whichever is later, जो भी बाद में हो. ठीक है, अगर फिट बाद में आया है तो फिट के 24 आवर्स बाद, अगर डिलीवरी बाद में हुई है तो डिलीवरी के 24 आवर्स के बाद. ठीक है, ओके. You should know that magnesium sulfate is a tocolytic also. Magnesium sulfate has no effect on BP. Please इस बात को समझ जाओ, बहुत गलतियां कर ली. मैग्नीशियम सल्फेट हैज नो इफेक्ट ऑन बीपी. मैग्नीशियम सल्फेट पूरी बॉडी में है ना, कहीं नहीं काम करता. ये जो हमारी सेरिब्रल वेसल्स हैं, इनको ये शांत रहता है, उनको वो हाइपोक्सिया में नहीं जाने देता, उनको जो है ये फिट्स नहीं पड़ने देता, बस यही काम है. मैग्नीशियम सल्फेट हैज नो इफेक्ट ऑन बीपी, नो इफेक्ट ऑन बीपी, नो इफेक्ट ऑन बीपी. एंटी हाइपरटेंसिव डज नॉट, and does, or जो एंटी हाइपरटेंसिव विच वी गिव लेबिटोलॉल एंड ऑल दिस थिंग, दिट डज नॉट डिक्रीज द फिट्स टेंडेंसी. फिट्स टेंडेंसी देखो, ब्रेन की वेसल्स में वॉजोस्पाज्म हुआ, तो वॉजोस्पाज्म की वजह से फिट्स आए थे. तो वॉजोस्पाज्म जो है वो फिट्स में ना बदले, उसको रोकता है मैग्नीशियम सल्फेट्स. Why we are so in fear that magnesium sulfate, the magnesium sulfate fits, दो magnesium sulfates दो fits ना पड़े, क्या हो जाता है अगर fits पड़ जाते हैं? What happen if fits occur? Fits can lead to permanent brain damage, because whenever there are fits, there is hypoxia in the brain. Permanent brain damage can occur. In the fits, the patient can, the aspiration can occur. Patient can aspire the contents into the respiratory tract, due to which the death can occur. So these are the two things. That is why we want that vasospasm of the cerebral vessels does not change into fit. That is why we are in the fear. And that the change of the vasospasm into the fits is blocked by magnesium sulfate. The change of vasospasm into vasodilation is blocked by antihypertensive. Okay, magnesium sulfate is neuroprotective because it is decreasing the fit's tendency and more important than antihypertensive. Okay, so what is the prophylaxis of eclampsia? Fits ना पड़े क्या करो? Magnesium sulfate, because magnesium sulfate, even if vasospasm is occurring, then also the magnesium sulfate will not let the fit to occur. And what is the treatment of eclampsia? Again magnesium sulfate, because if the fit is occurring, again the magnesium sulfate will stop the fit and don't let the second fit to occur. So in the case of the treatment of in the prophylaxis and treatment of eclampsia, both the answer is magnesium sulfate. Here I would like to tell you that in the management of preeclampsia, some points were left. If in the question retinal hemorrhage is given, then if we have to immediately do cesarean. If in the question retinal hemorrhage word is there, let me move the camera. Yes, if in the word question में अगर word है retinal hemorrhage has occurred, so if we will not or do immediate cesarean, the patient will become blind. Okay, if the in the word in the question the word is other than severe preeclampsia features, there is retinal hemorrhage, then you have to do immediately, you have to do cesarean so that the retinal hemorrhage does not change into the blindness. Okay, so now the vasospasm has transmitted to eye vessels, that is why retinal hemorrhage is occurring. So when the question comes first step in the eclampsia, your answer should be maintain the airway. If it is a definitive step, so why you were what is a definitive step in the eclampsia? It is termination of the pregnancy, because you know the root cause of the preeclampsia eclampsia is that spasm of the spiral arteries, that will be only removed if placenta is removed. So definitive step is remove the placenta or terminate the delivery, terminate the pregnancy. Now one question is also there in the twins, if the first fetus is breech, then what we do? Cesarean. The patient has came at 37 weeks, right? Patient has came at 37 week and patient had mild preeclampsia. Now in the twins we will not do the normal delivery, because it is a obstetric indication that the first fetus was breech. Okay, so here in the case of the twins where the first fetus is breech and the patient is having mild preeclampsia at 37 week, we will immediately do the cesarean. Okay, okay. Antihypertensive, this we have done. Magnesium sulfate, what are the effect of the magnesium sulfate on the fetus? Okay, so the effect of the magnesium sulfate on the fetus are the same effect that the magnesium sulfate is causing on to the mother. It is neuroprotective for the fetus. Now they ask that it does not cause respiratory distress, it cause magnesium from the mother goes into the fetus, and you know that magnesium decreases the respiratory rate. So magnesium does not, the option which was there in the question, magnesium does not cause respiratory distress, no, it is wrong. Magnesium causes respiratory distress, because जो सब कुछ मदर में होता है वही फीटस में होता है. Mother में neuroprotection is there, so in the fetus neuroprotection is there. In the mother respiratory rate is decreased, in the fetus respiratory rate is decreased, and in the mother there is loss of reflexes, in the fetus also there is loss of reflexes, or you can say there is hypotonia. What is prophylaxis of preeclampsia? The prophylaxis of preeclampsia is aspirin, okay, not labetalol. What are the prophylaxis and treatment of eclampsia? Both it is magnesium sulfate. It is clearly written. What is the treatment of preeclampsia? Definitive treatment is delivery or termination. But you tell me the antihypertensive drug of choice is labetalol. Okay, good. Thrombo-therapeutic level of the magnesiums, you should also know that it is 4 to 6. It is again a table of 4. Therapeutic level जो है ना 4 to 8 है. इतना narrow level है. It is so narrow, that is why magnesium toxicity occurs. इतना narrow कभी नहीं होता है level. सिर्फ इट इज़ हैपनिंग विद मैग्नीशियम. सो बहुत ही जल्दी पेशेंट मैग्नीशियम टॉक्सिसिटी में जाता है. सो यू शुड रिमेंबर दिस लेवल. yesterday many of you did wrong. 4 to 8 milli equivalent per liter. It is just the table of 4. 4 to 8 is therapeutic level. 8 to 12 is knee reflex. Knee reflex goes, respiratory failure occurs at 12 to 16. At 16, the last value of the respiratory failure, respiratory arrest occurs, and cardiac arrest occurs 25. So the first sign of magnesium toxicity is knee reflex. Okay, this magnesium is the most important topic of the preeclampsia. Okay. Similarly, there was one more table in the twins of 4 ka table tha. So in the first 4 days, if the zygote divides, then there is diamniotic, dichorionic. If on the 4 to 8 it divide, it is diamniotic, monochorionic. If 8 to 12 it divide, it is monoamniotic, monochorionic. If after 12 days it divide, it is conjoined twins. If we have to check the magnesium sulfate toxicity, we check it by knee jerk, respiratory rate, and urine output. The antihypertensive drugs, you all know this, so that's why I'm running. The best is labetalol in any condition. The best drug in any severe preeclampsia, in chronic hypertension, in the hypertensive crisis, anything they ask, the best antihypertensive is labetalol. Okay. Calcium channel blockers you can give, nifedipine you can give, alpha methyl dopa you can give, hydrolysis can give. Which cannot be given are angiotensin receptor blocker, angiotensin convertase enzyme inhibitor, that are losartan and captoprils, and furosemide. Next is predictive test for preeclampsia. There are 2 tests. One is rollover test. Normally when a pregnant lady lies down, there is suppression of inferior vena cava. Beta, you only tell me why you people mark superior vena cava syndrome there. Please don't mark superior vena cava. Jab the pregnant lady is lying down, inferior vena cava is below the fetus. Superior vena cava is here in the brain. How it will be suppressed by the fetus pressure? So when a pregnant lady lies down, hypotension is there because inferior vena cava suppresses. So what is this rollover test? Usually when a patient lies down, the BP falls because inferior vena cava gets suppressed. But if the patient has preeclampsia tendency, then we will make the patient to lie down and roll, then the BP will increase. In spite of the fact that inferior vena cava is suppressing, still the BP increase rather than falling. This is rollover test. Then what is uterine artery Doppler? Why we do? Now here the confusion is among the students is that they want to know that why umbilicus is not done. Because beta, the main etiology is spiral artery tunica media is not getting removed, right? So now you tell me कि if the spiral artery tunica media will not be removed, then effect will come in uterine artery or umbilical artery. First it will come in uterine artery. So the diastolic notching which occurs in the early pregnancy, it remains persistent. So in the fetus, effect will come late, beta. In the first, it will come in uterine artery. Spiral artery is a branch of uterine artery. I think we are on the last slide. Yes, cholestasis of pregnancy or help. In both of these, AST, ALT increases, liver enzyme increases, and jaundice is present. But how you will differentiate? In the cholestasis of pregnancy, patient comes with pruritus. ओके पेशेंट व्हाट इज प्रूराइटिस पूरी बॉडी में इचिंग होना पेशेंट कम्स विथ प्रूराइटिस पेशेंट का बीपी नॉर्मल होता है हीमोलिसिस उसके जो है नहीं हो रही होती है उसके ब्लड में प्लेटलेट्स उसकी नॉर्मल होती हैं तो सबसे पहले आप हिस्ट्री से पहचानोगे हिस्ट्री में पेशेंट क्या बोलेगा मुझे प्रूराइटिस हो रही है एंटी हाइपरटेंशन का पेशेंट कभी नहीं बोलता मुझे इचिंग हो रही है ठीक है हमेशा कॉलिस्टेसिस और प्रेगनेंसी का पेशेंट बोलता है कि मुझे इचिंग हो रही है ठीक है और इसका ट्रीटमेंट अर्सोडिऑक्सीकॉलिक एसिड होता है और प्लेटलेट्स कॉलिस्टेसिस और प्रेगनेंसी में नॉर्मल होते हैं कोई हीमोलिसिस का फैक्टर नहीं होता ठीक है थोड़ा सा जॉन्डिस होता है हेल्प के अंदर एएसटी एलटी इंक्रीज होते हैं माइल्ड सा जॉन्डिस होता है हीमोलिसिस की वजह से ठीक है और बीपी इंक्रीज होता है और प्लेटलेट्स डिक्रीज होते हैं लेकिन वो पेशेंट कभी भी प्रूराइटिस की हिस्ट्री नहीं देगा ठीक है हीमोलिसिस के फैक्टर्स उसमें फाइंड किए जाएंगे ठीक है आपको पता है पैथोलॉजी में कौन से हीमोलिसिस के फैक्टर्स हैं that's all about the troubleshoot video of preeclampsia see you soon in the next video do subscribe share like my channel so that I too can get my good profile in the teaching journey thank you